My name is Josina Romero O'Connell. I'm the director of Colorado Area Health Education Center, which is more commonly known as COAHEC. On behalf of COAHEC and the Anschutz Medical Campus here at CU, we would like to welcome you to the reopening and rollout of J.J. Cohen's Mini-Med. We couldn't be happier to be here tonight. We also have a fantastic speaker to open up. I just wanted to give you a few logistics. When Dr. Overbeck is finished with his presentation, we'll have a Q&A. You'll see some friendly students running about, getting the microphones to you. I also wanted to let you know that we're being joined tonight by attendees in the hundreds from people all over Colorado in rural, frontier, and urban areas. They'll be sending their questions into the chat, so we'll have a little back and forth turn so that everybody can have some of their questions answered. Okay. It's my pleasure and privilege to introduce Dr. Mike Overbeck. I have a little paper here because I could go on and on about his accomplishments, so we don't want to do that. Dr. Mike Overbeck completed his training in emergency medicine at the University of Michigan, and after a decade of practice in South Carolina, he arrived at the University of Colorado Department of Emergency Medicine in 2013, and he's still here. Dr. Overbeck is a successful and passionate medical educator. He has interests in critical care, cardiovascular disease, and medical student advising. He's been fortunate to teach learners of all age groups, starting from first grade to you name it. He's been recognized as a master educator at the local and national levels, and we're fortunate to have him here with us tonight to shed a little light on patients suffering heart attacks. Dr. Overbeck is my friend and mentor. Welcome.
Thank you, Dr. O'Connell. Well, I appreciate your attendance on a cold April night in Colorado, and I'm happy to entertain questions throughout the talk. This is a lecture that we often give our first and second year medical students. So if there's things that I say that are a little bit unclear or you'd like a little more information on what I'm talking about, please raise your hand or shout if I don't happen to see you, but I'm happy to take a moment and explain further what we're going to talk about. Cardiovascular disease in the United States is a huge burden. And the heart attacks we're going to talk about tonight are the ones we can actually pick up on an EKG. So over the course of my 20 years, I've obsessed about this little pink piece of paper that has all these unusual squiggly lines. Many people have seen them maybe from afar. Maybe, unfortunately, you've had the test done on yourself. Hopefully it's been okay. But boy, every little dot, every little squiggle we look at and sweat over. So hopefully I'll give you a little insight into that today. How do EKGs help us with heart attack patients, and how do we sort those out? I have no disclosures, but what we're going to talk about over the next 45 minutes really comes down into four main areas. What do the electrical currents look like inside the heart? What is then the process that causes heart attacks? And how do those currents change when the heart is struggling to give us a sign that maybe something is going wrong? And then how do we diagnose a heart attack and intervene on it? So we'll go into a little bit about what we do for people who have blocked arteries. So let's start off with a little basic physiology. Now in this cartoon, we've depicted a slab of myocardium, the heart muscle, and each myocyte or heart cell has a role in contraction and movement of the blood throughout the body. So when these cells depolarize or discharge, what we see is a tiny microcurrent. And physiologists have been doing this for over 100 years, looking at these various cell currents and trying to figure out what makes us tick, if you will. So we can pick up with these microelectrodes and we can see, as you see this little yellow ball, portray the depolarization. And if we measure multiple different myocytes, we start to see that they all depolarize at the same time. This is that upstroke that you see as it comes out, the upstroke, and then the downstroke is the repolarization. So we're resetting that heart muscle, that myocyte, for the next contraction. Now, this has to all be done in a very nicely coordinated fashion. Yeah, you might have a pound of heart in your chest, and that muscle, a majority of it, has to depolarize and squeeze all at once. Everybody's got to put their oar in the water and pull at the same time. If it's disorganized, we don't get effective contraction. We don't get good propulsion of the blood out to the body, and bad things can ensue. So we need that coordinated contraction. Now, in black, what you see here is something maybe a little more familiar. This is kind of the EKG representation on the surface of the body that is represented by these little physiologic cellular bursts. So when the cells depolarize, you see this big, tall, black QRS depolarization. And that's the entire ventricular muscle, the bottom part of the heart that does a majority of that work, squeezing all at once. And then this T wave is the repolarization. And these are set up vertically, so they happen at the same time. So when you see this red and this blue little individual myocytes discharging, that's represented by that big QRS depolarization. And then the T wave represents the repolarization, the kind of reloading, the resetting of the heart to get ready for the next depolarization. So those micro currents inside the muscle result in that depolarization and repolarization. And that's how we pick that up on the surface of the skin. Now, how do we know when to contract? How does the heart myocyte, how does it know? Because actually heart myocytes have a peculiar superpower, if you will. They all have this power of automaticity. Each little cell can generate a current and influence its neighbors. So if it wants to, it can really kind of go off on its own, sing its own tune, and do its own rhythm. But in those situations, people have really devastating circulatory problems. Talk about heart arrhythmias and things like cardiac arrest, where the blood's not flowing forward. That's what you can see. So what the heart has is a central system to depolarize in a coordinated fashion. And that's what we're going to talk about next. It's called the cardiac conduction system. Again, another cartoon. The top part of the heart are the atria. And you'll see here, let's see, there's the sinoatrial node at the very top. And we're going to show you how these depolarization pulses progress through this conduction system. You start at the sinoatrial node and you flow through the atria. They contract with that signal all at once, forcing blood into the ventricles to load them and make sure they're maximally ready to shove blood out to the rest of the body. When that first pulse comes from the sinoatrial node down to the AV node, there's a pause. And that pause at that AV node, we'll show you again here, allows the ventricles to just load up a little bit more. That last few percentage points of blood gets pushed down into the ventricles so they're really ready to spring and flush that blood forward. After that pause at the atrioventricular node then, the impulse continues down the His-Purkinje system in a split second and depolarizes 80% of the heart all at once. That huge amount of muscle mass that makes up the ventricles is depolarized in a concerted and coordinated manner. That, in a nutshell, is the electrical signals, the electrical activity of the heart. All this is going on 60, 70 times a minute without us even knowing about it. I'd wager that many of us sitting here right now don't even think about our heart, don't feel it usually. If we're running up the stairs, maybe we boost our rate up a little faster. If we're really scared about something or running a marathon, maybe we're up at 150 or 160 times per minute that this process is going on, okay? So let's talk about a little more about how we've detected this process. Now, certainly there was animal research going on in the 19th and 20th centuries where we're discovering these kind of conduction processes, the characteristics of myocytes. But the first person to really be recognized was a guy named Wilhelm Einthoven. In the early 20th century, he discovered that if you could somehow capture these currents that are traveling around on the surface of our body, it might reflect what's going on in the inside. So in this depiction then, Einthoven's placing his left foot in a soapy solution of in a metal container, his left arm, his right arm, and these are all hooked to electrodes. And when we look at the various electrical currents going over the course of the surface of our body, and we look at them from different vantage points, we can start to get a picture of what's actually going on in various times inside the body. Einthoven took that a little further though, and he put a piece of silk in a vacuum sealed tube, and that piece of silk had a little static charge on it. He placed one side of an electrode here, maybe his right arm was here, his left arm was here, and he watched how that little strand of silk moved back and forth. And he thought he saw a rhythm to it, but what ultimately nailed it down was he put a drum of unexposed photographic paper behind it and shot a light through it and watched that, I guess it was like this, watched the rhythm, the motion of that tiny charged strand, that fiber, as it cast a shadow on that drum. And he captured the first EKG. Now you can imagine this is not resembling anything in the modern world, what we do when we capture EKGs, but this is the first glimpse into, can we see inside the body what's going on and determine what pattern, what rate, what pathology is associated with these electrical signals coming from the heart. Of course, nowadays, if you come and see me in the emergency department and you have honestly pain from your nose to your navel, you're going to get an EKG. All right. If you were too fatigued to get out of bed this morning and your kid was worried about you and you show up in my office, you're going to get an EKG. All right. We're going to continue to be very vigilant about people with unusual stories. And so we do a lot of EKGs. Now, over the last 10 years, what we're starting to see is personalized technology. And there's even cases you can buy for your phone. I don't have one, but it has an electrode on the back on each side. You place your hands on the electrodes and it obtains the signals on the surface of your body and correlates that through some filters and gives you a single line of an EKG on your phone. Of course, that's 10-year-old technology, right? If it's on your Christmas list, the Apple Watch and maybe some others has electrodes on the back, and when it's closely adherent to your wrist, you can place your other finger on the bezel and actually get a signal just like this and measure your heart rate. Now, these kind of personalized technologies are all the rage, but we don't really know if they help us or not. So we're trying to leverage some of this technology. This may be one of the greatest, would you say, unconsented medical experiments going on right now, because so many people have these watches and so many people are coming to me and saying, hey, look, my heart rate was 160 today. Can we do something about this? We may have never seen that before. We may have never picked it up previously, but now that we have everybody watching their own health with these kind of gadgets, we're going to see this more and more. Now, I will say that Apple is quick to say that this does not check for heart attacks. So we're going to go through this a little bit more, looking for actual diagnostic electrical disturbances in the heart. Takes a little bit more of a sophisticated approach than just this single lead, what we might call a rhythm reading. So let's look at it a little bit more. Now, when you go into the emergency department and you have an EKG test run on you, you'll have these various stickers put on you. And I don't know, some people have them put on by EMS, then we tear them off and we put our own on. So you could have dozens and dozens of these things put on. But essentially, this map shows you where the stickers are placed. So you see there's some V's and some numbers. For example, V1 is a particular lead down here between the 4th and 5th rib, just to the right of the breastbone, the sternum. And V2 is its partner over on the left side in the 4th intercostal space. And then we put V4 down here kind of right directly below the nipple, and V3 splits 2 and 4. And then we do V5 and V6 down in the armpit. And then there's these RL, which is right leg, left leg. Up at the top is a little bit obscured, but you also have stickers on the right shoulder, left shoulder, or even further down in the arm. And these are stickers with leads that are detecting these microcurrents on the surface of the skin. So we're looking at what kind of electrical signal are we getting? And we're not just looking with one single sticker, we're looking from a lot of different angles. And I'm gonna give you some more information about that as we go along. Now, these next few iterations, these 3 or 4 beats we're gonna go through, are gonna bring together the conduction system we talked about, with the pulses starting at the sinoatrial node, going down to the atrioventricular node, pausing for a moment, allowing those ventricles to load, and then immediately, like a lightning strike, depolarizing that ventricle. But we're going to compare it to what you might see on your Apple Watch underneath it there, that rhythm strip, that single lead EKG. So if you watch the SA node fire, the AV node pause, and then the depolarization and repolarization. So that big red wave is that repolarization where the ventricles are getting ready to go again. We'll do it again here, the SA node down to the AV node. Then the QRS complex fires all in a very short amount of time, right? It's a huge amount of muscle depolarizing all at once to give us an efficient contraction. This is our last one here. It goes through, you repolarize, and you're done. Now, that's what we're talking about. We're looking at an electrical signal of a pretty important organ and registering those signals and those perturbations on the surface of the skin. If we're looking at this a little more carefully now, we're getting into the weeds a little bit with the detailed representation of those signals. So if you can see here, there's a P wave to start on the far left, and that P wave is the atria. They're kind of thin, kind of flimsy, super important, but they have a small voltage and they don't really contract quite as uniformly. So it's a little broader wave. It's kind of a nice, relaxed wave. Then you see that PR segment. Now that is when that impulse gets to the AV node. That's just the pause to allow the ventricles to fill. And then, bam, QRS, that is this huge deflection here. It starts with the Q and the R and the S, and these are, again, conventions that we use to name these waves. That signifies the ventricular contraction all at once in a moment in time. And then the ST segment is just this pause where all these myocytes that did all this work now just pause for a moment and then start their repolarization process. And the repolarization is that T wave. So this is what we're going to talk about now. These squiggles. People are talking about, oh, are my bumps going up, my bumps going down, whatever. The point is, this is what physicians are obsessing about. Your cardiologist will obsess about this, your family medicine doctor, your emergency physician. We're all going to be interested if this looks normal or not, because we want to know what's going on with your heart on the inside. Okay, so we've covered that first part. Now, what do those currents inside the heart manifested as on the outside, on the surface? What can we detect? Okay. Let's talk about things that cause heart attack. And this is maybe something that's more, maybe we hear more about this typically. So what's killing us? I don't know. I will tell you, I had a Diet Coke for dinner tonight, and this looks delicious. So I'm not gonna lie to you. But there are risk factors for heart attack, heart disease, stroke. They tend to run together, these cardiovascular risks. And things that are non-modifiable, or things we can't change, right? You can't change who your uncle is. You can't change that your birthday comes around every year. And you can't change your sex, really. I mean, males are more at risk for this. So the idea that there are non-modifiable risk factors, that's pretty important in how we think about patients at risk for heart disease. But then there's all these important modifiable risk factors. And if you have a hard time remembering this, just think of yourself sitting down in front of the Avalanche hockey team, watching a hockey game. What do you do there? I don't smoke, but boy, I'm inactive. I'm eating a hoagie. I'm getting stressed out about things I have no control over. And that is a lot of the risks for developing coronary disease, right? Cardiovascular disease. If you can stop smoking, great. If you follow with your physician, get your cholesterol under control, get your blood pressure under control, that's great. Start on some graduated exercise, walk to the library once in a while. Control your weight, try and make sure your diabetes is being checked. And then everything in moderation. Moderate your stress, moderate your alcohol, moderate your diet. Now, for years, we've studied decades. I think a reasonable objection to medical research has been that we focus on white males. And white males tend to have heart attacks with anterior or chest pain in the front of their chest. Classically, it radiates into their left side of their head and maybe down their left arm. They get some shortness of breath, nausea, sweaty, and then they don't go anywhere until their wife tells them to go to the hospital. That's the classic presentation of heart attacks, right? But now we know that all kinds of people are susceptible and people present differently, okay? That kind of squeezing, tightness. People have said a refrigerator or a belt is on my chest. Some people complain, my bra is too tight. It's not like this. This is unusual. It can be really subtle. But we're thinking now more and more about how different populations experience cardiovascular disease and even acute heart attacks differently. You'll see this term radiation. What that means is pain is felt, yes, in one place, but it also it tends to move or to shoot out or project in other places. Sometimes it projects to the back in between the scapulae. Sometimes it projects to the other arm. And in fact, we know now that it's probably just as likely that you're having a heart attack if you have left arm pain as right arm pain, or maybe more so with right arm pain. And maybe women get right arm pain more than men. And bilateral arm pain could be really important to pay attention to and get checked out for. And then the shortness of breath, sweats, nausea, feeling terrible, but it's all of a sudden, right? It's not that you just have the flu. You actually have something terrible inside your chest, going wrong. And we can't really, our bodies don't always register that as the classic heart attack, the chest pain in the front, radiating out to the shoulder and the neck with some sweats and shortness of breath. So as emergency physicians, we are really fanatical about checking EKGs. We want to check the heart routinely. Now, I've not practiced as a family medicine doc. I've not practiced as an internist. I don't practice as a cardiologist. I practice in the emergency department, and I think anybody who wants to can have a heart attack. If you want to have a heart attack 2 hours after Thanksgiving dinner because you ate too much and you just feel full and a little sweaty and a little nauseated, and you come to see me just because I need my antacids refilled. But we do the EKG and we find something more serious going on. So I think there's a lot of people out there that we are now more aware and checking more aggressively. Younger people, older people with more vague symptoms, older adults, they might just have a little shortness of breath. I was walking out to my mailbox at the curb and I had to stop a couple of times. That's not like me. Could be a heart attack, right? Just fatigue, I don't know, grandpa didn't want to get out of bed today, so we're bringing him in. Simple, vague things like that can be really important. Let's look at this now. This is the disease and the blood vessel level. So when we're talking about heart attacks, we're talking about blood vessels getting blocked off. So we're going to spend some time talking about the process by which these blood vessels become blocked. Now, on the very far left here, you see it says first decade. What we know is, I don't know, I'll just run down the diet of my 6-year-old recently, right? Pizza, Skittles, this month, Rice Krispie Treats is like the vegetable, okay? And we know that that affects us. This Western diet that we have, now he's running around on the soccer field doing playground stuff, all kinds of things that I can't keep up with. But he's starting to develop these trace little lipid depositions in the wall of the arteries in his body. And sadly, we know this because we do autopsy studies on kids who die unexpectedly, typically accidents, motor vehicle accidents, for example, firearms accidents. And we see the early signal that there's a little bit of fat deposition, a little bit of cholesterol plaque developing. They're not called plaques yet, but it's a fatty streak that kind of sits in the wall. And then when you're off to college and you're invincible, you can eat whatever you want, drink whatever you want, right? A 6-pack of Coca-Cola and a pizza, that'll get you through most of the weekend, right? We start to deposit more and more fat into that wall, the cholesterol. These tiny little depositions start to add up. And so even in our 20s, we start to recognize cardiovascular disease with our diet and our habits otherwise is starting to have an impact on those vessels. Take it further from the 3rd decade. So in our 20s, maybe in our late 20s, we start to actually have a deposition of this kind of inflammatory gunk, this muck, this thick peanut buttery core that's trapped by a nice candy shell, nice and smooth, but we continue to build that plaque up, even as a 25 or 30-year-old person, right? And if we're smoking and we have diabetes and we're sedentary and we're overweight, it's going to accelerate that process. If we got Uncle Bob and Aunt Sue who also have coronary disease, we probably have some genetics involved, and we don't completely understand all that, but this process is continuing. Now, as you get into your 4th decade, right? So in your 30s and 40s, these plaques can get bigger and bigger and start to, if you look at the cross section, it's really encroaching on the total width of that blood vessel. So now maybe when I was 25 years old and I was at the family reunion playing flag football with everybody, I was doing great. But now as a 50-year-old, I can't keep up. I get a little short of breath. Well, my knees give out, but that doesn't have anything to do with tonight. But we worry that that narrowing can be a signal, or it can actually manifest as shortness of breath, fatigue, exercise intolerance, and maybe even some chest pain or discomfort. Now, the problem is in that last panel there on the far right is when that nice candy coating kind of ruptures and allows that internal core to be exposed to the passing blood. That internal peanut buttery kind of sticky stuff is really annoying to the body. And the first thing it wants to do is respond to it, attack it through an inflammatory process that involves blood clots. It recognizes that internal core as foreign and it wants to glom onto it quickly. And so the problem that we have is we get clots that now we were narrow, we were doing okay, we were kind of keeping up at the family reunion. But when that clot forms, it cuts off all the blood flow to the distal portion or the later portion of that vessel. And all those cardiac myocytes downstream are now struggling. Let's look at it as a kind of a cut or a transverse section, okay? So we're looking at the artery on end here. We just took a cut. Maybe this is in our 20s or 30s. We got an atheroma developing, some fatty deposition, but it's wide open otherwise. We're doing okay. As it progresses, smoking, diabetes, hypertension, sedentary lifestyle, we start to deposit more and more of those cholesterol plaques. We have white blood cells coming to that area to try and attack that and clean it up, but they die and there's more debris and we get more and more blockage until one day that plaque ruptures, exposes that core, and generates a clot. And as you can see now in this cut section here, that clot takes up the little bit of remaining passageway for the blood that we had. So we've completely occluded that coronary artery. And that's when the trouble starts. Because we can't supply blood to those myocytes that are working hard, right? We're just hanging out here. We're 60, 70 times a minute. It's beating. We don't even notice it. It's working hard, though. There's a lot of work going on. It needs oxygen. It needs glucose. It needs to wash away all the cellular kind of byproducts of metabolism, get that waste washed out. And it can't happen when there's that clot there. Now, to get even more specific, I want to talk to you about these vessels. So this is a plasticized model of the heart. And what the anatomists do is they choose the right coronary artery in yellow, and they squirt a little bit of yellow plastic in there. It's liquid to start with. It goes down and it kind of distributes everywhere that right coronary artery serves in the heart. So that whole yellow side is this big, massive muscle, heart muscle, that the right coronary artery serves. And similarly, the left coronary artery serves all this red area. So they shot a little red plastic in there, and then they dissolved all the tissue away. And you can really see, the heart is very metabolically needy. And it's got a ton of blood vessels, big and small, serving all those little myocytes so they can continue to do their work. Now, by convention, we're talking about some naming here. The right coronary artery is called the RCA, the right coronary artery. The left circulation has two big arteries. The left front artery that goes down, or left anterior descending artery, the LAD, that comes down on the front wall of the heart. And then the circumflex, or circ, goes around the back and serves the back of the heart. So we've got two main arteries coming off the aorta that then serve the whole heart, and that left divides into the LAD and the circ. Now, we've talked a lot about this process, right? If we get a blockage, what are we doing? Well, what if we block that LAD from the moment it starts that clot? We jeopardize everything downstream of there. And when you cut off the blood flow to these myocytes, they don't just stop right then. They don't get blood flow from other places, usually. But they are screaming. They're being smothered right now, and they're shouting out for help. And one of the things they do that we're going to talk about next is they change their electrical signature when they're struggling. Okay? So we're going to talk a little bit more about how these struggling, this kind of blue shaded area that's not getting blood flow, we're going to talk about how that blood flow decrease changes their electrical appearance. All right, so we've got the currents inside. We know that triple cheeseburgers cause heart attacks. Now we're going to talk about these currents inside. So let's go back to this diagram here. What we're going to focus now on, and again, all these bumps and squiggles have a purpose. They have something they're representing. The P wave there, the atria, the QRS is the one big thunderclap contraction of the ventricles. That ST segment in between, again, we don't know everything about this, but that's a little pause before the ventricle starts to repolarize. And the repolarization is that T wave. But we're going to focus on the ST segments. So normal, right? Hopefully everybody here has a nice normal. We don't have the P wave captured here, but we've got a nice normal, narrow, tall QRS. That's that ventricle depolarizing. There's that nice, well-behaved ST segment. It's right down at the baseline, right on the, what we call the isoelectric line, that from which all the other currents are kind of measured. And then that nice normal T wave, okay? Now think back to that yellow and red plasticized model when we put the clot in there and we stop that blood flow to that downstream area. Within minutes, the EKG manifests some changes that are really key to the clinician who's trying to pick up a heart attack. Within minutes, the ST segment jumps up. And I don't know why. I don't think as a medical specialty, we know why it changes its characteristics like this. But what I think about is there's a giant scream that goes out, right? These myocytes are officially struggling. They're officially unhappy, and they give us this electrical pattern. Now, if you're sitting at home and just hanging out, that's fine. You got a little nausea, you felt a little twinge, maybe something, I burped a little, I don't know, I hadn't felt this before. It might not be tremendously noticeable, but this is what's going on in those first few minutes. Over hours, we still haven't snuffed out those myocytes. They're still in there screaming. There's a chance we could do something for them if we could just get blood flow back to them. But right now, that ST segment is still up. Now, if you're noticing too, just to the right of that, the T wave has flipped and gone down. Now, that's going to be a signal about, some other things we'll talk about in a minute, but I just want to draw your attention that T wave is changing and the QRS is changing. So if you look in box A, there's a tiny little negative deflection or downward deflection, very small. Wouldn't even notice it. But now after hours of us kind of putting the chokehold on these myocytes, there starts to be a bigger negative deflection. After days, the ST segment goes back to the normal baseline. And it's not because we fixed anything, but it's because those struggling smothered myocytes no longer are represented in the electrical signature. There's some other myocytes that are around the area that are still irritated, and that's that big T wave that's pointed down. And you notice that first deflection of the QRS is still down too. Finally, maybe the T wave goes back to normal and we're left with this big negative deflection of the QRS. It's like a scar of the heart, okay? And that's the electrical signature of this patch of myocytes that are not working. So when we cut off that blood flow, we just talked a lot about how that ST segment jumps up. And now we're going to just talk a little bit more about it. Now, in this patch, again, this other cartoon, there's a dark area right in the center, right? If you think about a bomb going off, people aren't injured right where the bomb goes off. People are killed instantly. And so minutes or maybe hours, this dark area in the middle is an area of dead cells called infarction. Then there's a halo outside of that called injury, where the myocytes are pretty irritable, pretty tough to recover, but they need some help. And then finally, further out is a term we use to describe these at-risk areas called ischemia. And if you notice, each of these areas has a little bit of a different signature. That EKG appearance is slightly different. So in the area of infarction, the EKG signature there has that big negative deflection. Those are dead myocytes. It's a scar. If you go up to the pink area, the area of injury, that ST segment is up. It's jumped up. Those injured myocytes are crying out electrically, we need help. And then finally, ischemia, there's some T wave inversions there, T waves that are negative now instead of positive. So the repolarization in that area isn't quite right. Now, they'll probably recover if we get some reasonable attention, but there's an area there, a halo, if you will, around this infarction and injury that is also at risk. Please. Yeah, so the question is, how do we find the difference between these three different things? How do we localize maybe? Is there an infarction there we're looking at, or is it injury? And so we're going to talk a little bit about that because that's a key part of using EKGs to localize where these changes are going. So not a plant, but an excellent question. Thank you. All right, so we're going to now look again at this cartoon where we put the stickers on your body, but we're trying to portray a three-dimensional organ in our chest that's changing in a fourth dimension of time. And we're trying to represent that on a two-dimensional piece of paper. So I'm going to take you through that just in the next couple minutes and make sure that you understand what we're talking about. So again, another cartoon heart. And I'm going to say the yellow here is that right coronary artery. It serves that right side. There's some salmon colored arteries here that serve the wall between the two ventricles, the septum. This blue cartoon here is the anterior descending artery down the front. And the green is the circumflex around the back. Okay. So again, same kind of things we've been talking about, slightly different cartoon, right coronary in yellow, left anterior descending in blue, circumflex in green, and they serve those areas of the ventricle, right? They're serving those areas of the heart. Now, we look at the heart through various camera angles, okay? So in these green areas, again, these letters, right? This is the convention that we're left with. These green areas, you have AVL and 1. They're looking at the heart kind of from the shoulder. V6 and V5, well, those stickers are right here. So I'm looking at the heart from that kind of side wall, or what we call lateral wall. And then inferiorly, you see, if I'm standing there, well, lead 3 is looking up from my right hip pocket, like a camera in my pocket, looking up at the bottom of the heart. Lead 2 is looking up from my left hip pocket. And then we've got AVF looking up kind of from my belt buckle. So they're looking at the bottom of the heart. And then we look at these septal leads. Remember, we put V1 and V2 right here. They're kind of looking right at the wall between the right and left ventricle. They look right there in the middle. And then finally, excuse me. Finally, we have the V3 and V4, the anterior, the front part of the heart that we're looking at. Now, this is all well and good, Dr. Mike. We've got all these different camera angles we're looking at, but this doesn't look anything like an EKG. And this is the problem, right? Some of the training comes from knowing where these camera angles are and where do you find them on a conventional EKG that we obtain. So somebody with much more experience than me decided this was the layout, okay? Now, if you see the greens, V5 and V6 are down here, but 1 and AVL are up there at the top left. Stevenson, I don't know if can we make that black bar go away? It's not on my screen. It's just the Zoom stuff. But yeah, because thank you. Oh, more. Wow, thanks a lot. We talked about the inferior leads, 2, 3, and AVF. They're down here in the left corner. The septal leads, V1 and V2, they're kind of in the middle, and that's fine. But V3 and V4, they're separated spatially on the page as well. So I've got all these different camera angles scattered all over. And I'm trying to look at the heart and make determinations about if there's an artery or an injury pattern that's specific to an area in the heart. So when I superimpose that map over the EKG, I start to get an idea of here's the leads and here's where the injuries might be. So that regional look that we're doing with these various stickers, these various camera angles, it tells me which parts of the heart I'm looking at. Now, honestly, there's even more leads than just the stickers we've talked about. There's actually a I don't know, it's like a huge foam sticker that applies to your chest, wraps into your armpit, and wraps around your back. And it has upwards of 200 leads. So we start to develop like a heat map of your heart. We can look at not just these 12 discrete areas, but hundreds of different angles. Now you can imagine when you peel that off, it's quite painful. And so the Geneva Convention prohibits us from using that kind of technology. But the idea that you can get more and more views of the heart if you apply more and more leads and look more specifically in these areas. Now, we're going to go through a case here because these ST changes, these ST segments that we're looking at, these myocytes that are screaming out, when they scream out in a particular area, it helps us make a diagnosis. So try and keep normal in your mind, and we're going to do a clinical case here. 49-year-old male. This is a picture off the internet, not the patient. Complains of chest pain this morning. It's achy kind of feeling in the center of his chest. He's got a history of high blood pressure, and he's been smoking for 32 years since he was 17. And this is his EKG. Now, it doesn't look nice and normal like the previous ones we've talked about. But if we look at the QRSs, they're nice and narrow, and they signify to me a well-regulated, well-coordinated depolarization. But then right after that, I'm looking for any of that ST segment elevation. And if you see it, you're doing great, because what we're looking at is in the inferior leads, 2, 3, and AVF, they actually have some ST segment elevation. And then there's a tiny bit more out at V5 and V6 out here on the right side of the EKG in those lateral leads, okay? Now, we've identified these ST segments on the EKG. Many of the other leads have abnormalities we won't talk about in this lecture, but these are the key leads that have the changes we're looking for. And so when we put these leads there, how do we make heads or tails of the anatomy of this? Is it anywhere close to each other? Well, we know the inferior leads go to the bottom, and we know those lateral leads are out there. So then we're talking about this person may have a heart attack down at the apex of the heart. We see those screaming myocytes in the inferior leads looking up, and we see screaming myocytes looking at the heart from the lateral aspect, and what we would call an inferior lateral ST elevation myocardial infarction. I want to bring that back up for you here now. Those ST segments are up in 2, 3, and AVF, and up a little bit in V5 and V6. So they come to see the cardiologist. We know that clot is going on in that vessel. The cardiologist goes in with a catheter, right, in a percutaneous coronary intervention, or what people say is, I went to the cath lab for my heart attack. We suck out the clot. We place a fine balloon down in that area with a little metal cage, and we deploy that metal cage, and it squeezes that vessel back open. It doesn't change the disease process. We still have fatty deposition from all that pizza we ate in our 20s, but we've pushed it open and restored blood flow. Here's another cartoon. Now, we wouldn't take this person that I'm describing in this case to the CAT scanner, but we did come across a patient with similar symptoms, but not anything abnormal on their EKG, and they have a blockage. And what we're talking about here is this big artery coming off the side just stops abruptly right there. It should continue down this groove. That's the right coronary artery. It's blocked off completely. And with CAT scan technology now, we can get these kind of images, which are super cool. But what you're seeing is a kind of chronically or long-term blockage. It's similar anatomy to what our patient has, but a totally different clinical situation. Again, that right coronary artery is coming down to your left side of the screen. We're going to look at this patient's catheterization. So we got him to the cath lab, 30 minutes or so after getting that EKG. The cardiologist goes in through the radial artery and threads a fine catheter into the right coronary artery and squirts some dye in it, okay? Now, when the cardiologist squirts the dye in, you can see that big right coronary artery, that vessel, right? On the cartoon, it looks the same. There's a little wire in there. That tells the cardiologist where they're going. That helps them kind of navigate. And you can even see a little bit of contrast reflux back up into the aorta. But right at the tip of the catheter there is a little bite, right? There's a little area that doesn't get contrast, and that is the clot. That's the atheroma. So the cardiologist next goes in, sucks clot out, puts the balloon in, deploys the cage, right? And that's what you're seeing here. The right coronary artery now has a stent in it. And then after that, the cardiologist shoots a little more dye and says, hey, look, Look at my handiwork. And in this first portion, these first few frames, you see now there's no more bite out of that. It's open. It's got a mesh in there. And blood flow is continuing. And what the cardiologist is doing then is, do I have any more work to do in this right coronary artery? So he's kind of panning down the remainder of that because he knows that there was some inferior and some lateral. So he doesn't want to miss something way down there. So he pans over a little bit. That right coronary artery gave us this EKG. And the providers were able to make that diagnosis and get the patient to the cath lab. So to conclude the case, 49-year-old male, he stopped smoking. He was quite motivated. He had better blood pressure control, started on a graduated kind of observed exercise program. He takes aspirin to make sure his platelets in his blood are not too sticky, and another medicine called Plavix, which is also an anti-platelet agent. And he took some metoprolol to make sure his heart rate stays low and his blood pressure is good. And he's doing better. Well, the last we heard, 2 years after that, he was doing great. So we've got currents inside that can be detected outside. We know that changes in the EKG can be signals to arteries that are blocked. ST changes can localize disease. So in the right coronary artery, we might have a very characteristic EKG. The left coronary artery or left anterior descending, we might have a different EKG. And those EKGs are great screening tools to help us. And with that, we're getting up against it, but I'm happy to answer some questions. Thank you very much for your attention.
Ooh. Thank you, Dr. Overbeck. What we're going to do is take turns answering questions from the audience. So, and then our groups that we have out in other parts of Colorado. So if you can raise your hand really high, we like those groups in everywhere to hear your questions. So I'm going to pass this on.
Can you address silent MIs?
The question was silent MIs. And the way I would say we typically use the phrase of silent MI is, I'll use myself as an example. I'm coming here, I hear this class is subscribed to the hilt and I'm going to be talking in front of a lot of people and I get a little twinge, right? I say, oh, that's probably just that Diet Coke. It's not anything concerning, right? So I can imagine in my patients who have had quote unquote heart damage from a silent MI may have had something where, yeah, I was feeling a little rough one day, had a little something there, and it must have been the pork chops I was eating or something, and it went away in a couple hours. These are the kind of things, because these myocardial infarctions, these silent MIs don't behave, they haven't read the book, they don't obey the rules, they actually can present differently. Maybe it's a tooth pain that you went to see your dentist for, something as seemingly innocuous as that. Turns out, in retrospect, maybe it was some of your heart that was at risk. Does that help? The question is, does it show up on the EKG? Sometimes yes, sometimes no. We are learning a lot. I think in another 15 years, we're going to look at EKGs and say, wow, we were using that to make these diagnoses. We're getting more blood tests, more imaging tests. It seems like every 5 years, there's more and more tests that are going to give us a better answer, a better picture. And so the EKGs may not be, and probably are not, the best test for it, but it's what we have right now. And so we can miss these. Yeah, they don't always show up. You also think like we're putting stickers here, but we don't really put stickers over here. So we're not really looking at the whole heart, and we miss some places. And sometimes these changes are subtle. So silent MIs don't always behave the way they should with symptoms, and they don't always show up when we're looking at the EKGs.
Hi. Okay. So we have a question from the chat. It says, when a patient is immunocompromised and doesn't have a proper inflammatory response to indicate an abnormality, would the EKG appear differently, or would there be other diagnostic tests?
Yeah, it's a great question. So there are a lot of treatments we have now that are aimed at decreasing our body's immune response. We think even that diabetes is kind of a slow burning inflammatory response that's just happening all the time. In these situations, there's a couple of disadvantages these patients have. If somebody's on some chemotherapeutic agents, or maybe they have lupus and they're on other agents that are suppressing their immune system, they may not manifest pain or nausea or shortness of breath the way we might if we are not taking those medicines. They also may not show us a normal EKG to begin with, because there's low levels of inflammation in all parts of our body, and people with rheumatoid disease or lupus or cancer and are on chemotherapeutic agents, they're living in an inflamed kind of state. And so we're adding medicines to balance that. And so these people often come with an EKG that doesn't look normal to begin with, and picking up changes in those people is even more challenging than what we've just gone through here. So the symptoms are often muted or absent. It's kind of silent MI again. And the EKGs can be even more challenging to pick up things. We just want to make sure everybody can hear it. It's logged in.
Can you tell me what ablation is?
Okay. The question is, what is ablation? Ablation is aimed at decreasing arrhythmias. So if people have a heart rate that's too fast, or they have extra heartbeats, or sometimes extra heartbeats that pile on top of each other, can be really life-threatening. One of the more common terms you'll hear is atrial fibrillation. The top parts of the heart are really beating, and it's not this nice coordinated sinoatrial node, goes down to the AV node, pause for a moment, then lightning strike, depolarize the ventricles. The atria are just kind of doing their own thing, and that makes us have sometimes a little bit faster heartbeat. Other people will have arrhythmias that are really dangerous, and so the cardiologist will go in with a catheter into the heart and seek out, it's really cool, they map out those green kind of conduction pathways that we showed you on the cartoon. They'll map it out and they'll find an area that they think is causing the problem. And they'll either freeze it or burn it or inject chemical into it and stop it from working. So it's like if you've got a loose wire in your house somewhere and your lamps are always blinking, if you can go and find where that loose wire is and put some tape around it so it stops shorting out, lamps go back to normal. And that's what an ablation does. It goes in and kind of knocks out a problematic circuit. Does that help?
Yes, thank you.
Okay. In the cast video, it looked like there was a leakage of blood from the vessel at the big flexion point. What was that? Would this have been happening all along? Is it a problem?
So the question is about a leak of some of the contrast. Now, I will say that the aorta is the huge vessel that comes off of the heart, right? So the left ventricle pumps through the aortic valve, and then this big garden hose, a couple centimeters in diameter, comes out and serves all the blood to the rest of the body. When the cardiologist goes in, they're sticking this catheter kind of in the radial artery and coming up through the subclavian system and getting down to the arch of the aorta, going back to the very base of the aorta, right where there's this tiny hole called an ostia, and that's the opening of that right coronary artery. When I stick my catheter in there, I shoot a little dye. Most of that dye goes down forward, but a little bit of it refluxes back up into the aorta and shoots off into the rest of the body. It's not dangerous, it just happens. But if you get your catheter fitting that orifice pretty well, you get very little refluxing back and you get the dye down that artery so you can see where the problem is. So the refluxing of that dye or that contrast agent is not serious and happens routinely. Is there one?
Is there some way to determine just how clogged our arteries are? I get this stuff in the mail sometimes, and there's all these advertisements to find out how clogged my arteries are. Is really an EKG the best way to determine if I've got problems or if one has problems? Or is there another test that we can take to see how far I've clogged them?
Okay, that's a great question. In many ways, individually, right? It's something we're all concerned about. Like, how much couch sitting can I get away with before I've got serious disease, right? And what I will say is, much like my plumber today came over, scoped our sewer line all the way out and charged us $89. But what are they charging you? $89 because now they just found like $6,000 worth of problems, right? And it just reminds us that when we start having tests and looking for trouble, like Dad used to say, right? When you look for trouble, you're going to find it. Now, there's various tests we can do. Screening EKGs, probably not that useful in the regular healthy person. So if your church has a little, I don't know, an event, between noon and 2 after service next Sunday, and you want to stay after and get an EKG, it's probably not going to be very, what we would say, high yield. It's not going to help much. But with the coordination of your primary care doctor, your internist, your family medicine doctor, you're getting an outpatient visit, we can then kind of assess your risk, right? If your cholesterol's a little bit up and you got a family history of a couple people with heart attacks in their 50s, and maybe you were smoking for about 10 years, but you've quit, thank goodness. Now we can start to get a sense of you're at medium risk, maybe for heart disease. And if you start to have symptoms or other triggers, we might do things like stress tests, where we put you on the treadmill and hook you up to an EKG and really put your heart through its paces and say, okay, heart, can you hack it? Or do you have some narrowing in there? And do your myocytes start to get a little irritated? Do we see some changes on the EKG during that treadmill kind of test? There's other things where we can inject different radioactive tracers and look at the blood flow into your heart. We can use MRI machines to look at the heart, CAT scans to look at the heart, do things like calcium scoring to look at the burden of calcium inside those vessels. Problem is, when we're looking, we don't always know, oh, that's the reason you're having heartburn, that calcium, right? That calcium might be there. It might have been there for a decade, never given you trouble, maybe never will. But when we find it, then it starts to maybe open a Pandora's box of, oh, let's look further. Let's do more. Let's do more. And going to the cath lab is a high risk endeavor, right? Maybe 1 or 2 in 1,000 people that go are going to not live through the procedure. I mean, it's not dangerous. If you need it, it's perfect. But we don't do it to just everybody looking for trouble, because we cause more trouble in those situations than we do. So I would say, always consult with your physician, right? That's the typical disclaimer. But we can think about this in a nuanced way. Well, you never smoke. You have a good family history, and you run a marathon every 3 months. Okay, that's a different cardiovascular risk profile than Dr. Overbeck has. So you're probably going to be doing great. But we all hear these little anecdotes of people who have great lifestyle and then one day just have a terrible cardiac event. So we're not great at predicting it, but the one thing we can control is kind of risk factors, and that's what we're trying to address in the outpatient setting.
We'll take one more question from the chat. And if you don't mind doing our survey, that's one of the ways we'll count you for your diplomas and your pins.
Okay. What causes acute MIs that result in the tombstone ST segment elevation? And what kind of treatment does a patient receive when they show tombstone ST elevation?
Okay. So the question is about what's called tombstone myocardial infarction. And this is, again, if you recall some of these changes we talked about with the ST segments, there's a particular big territory of myocardial infarction or blockage that of an artery that serves a huge part of the cardiac myocytes. And when you get that many myocytes screaming, suffering, the ST segments jump so high up, they almost blend with the QRS and the T wave, and they form these big, I don't know, almost like the old Pac-Man ghost, that shape, that round shape. And people have called those tombstones because the area of the heart that is affected results in these dramatic changes in the EKG. That's something that needs immediate attention. And the more heart that is affected, the higher chances of not surviving that heart attack, the higher chances of arrhythmia, the higher chances are, even if you do survive, you're going to have problems later on. So tombstone is a term that we use that kind of describes those ST and T wave segments. But it just tends to mean people have a higher portion of their heart that is affected. And those myocytes are numerous that are suffering.
Thank you so much, everybody, for being here tonight. Please join us next week for Dr. Maurice Scott, who will be presenting on end-of-life care. Dr. Overbeck, that was fantastic.
Thank you.
Thank you.
Thank you for being here. And I'll say, Dr. Scott is a friend and a mentor to me. You'll never meet a kinder, more competent physician. I don't know what his subject matter is, but it's going to be outstanding. So thank you for having me, and make sure you're here next week.